Hypertension has been changing, and so what I want to do is give you the most up-to-date hypertension guidelines that we can. I'm not going to run through the guidelines one at a time. They actually have a very good document. I mean, it's not 1,000 pages, but the pages with the color on them are where the guidelines are, and they tell you how good the recommendation is. It's actually very well laid out. So if you need to look up the guidelines, they're there. And if you need to use the calculator, I'll show you what I mean, it's there. So what I want to do is try to find a way to help you keep this straight when you don't have access to the guidelines, when you're on the fly and you don't have a calculator. Right. The big change in the most recent guidelines was the ranges. We're going to classify blood pressure either by systolic or diastolic, and that's going to put us into a stage. And based on that stage, we're going to treat. We defined normal now as being less than 120 over less than 80. In this case, you must be both. This was a big change, basically putting 50% of the US population not normal. And that's okay. The idea was as the blood pressure begins to creep up, let's intervene by talking to these people sooner rather than waiting for them to actually have hypertension. And with these patients, since they're doing so well on their own, sure, you can tell them about lifestyle modifications and you can tell them keep doing a good job, but really what it comes down to is follow-up, which needs to be every year. The stages from there have been redefined as elevated BP, stage 1, stage 2. And then as we get into the hypertensive crises, urgency and emergency, we take a big jump. We're going to talk about these separately very briefly. What I want to focus on is chronic outpatient management of hypertension. Elevated BP has now been defined as less than 130 over less than 80. That's the limit for the elevated blood pressure. That's also what our goal is going to be for most patients. We do have in there, towards the end, we're going to talk about special patients. Don't try so hard, still works. The patients who have a slightly elevated systolic blood pressure, it has to be the same range as normal for diastolic, needs to have a discussion about lifestyle modifications. Yeah, the test loves lifestyle modifications. What are lifestyle modifications? It comes down to eating, your diet, exercise, and ultimately, weight loss. Now in the guidelines, they actually have a thing that says like you can potentially lose this many millimeters of mercury above blood pressure if you get this. What I want you to see is that if you change your lifestyle a lot, you can really take down the systolic blood pressure. The diet comes down to a couple of things. Now remember, water follows salt. So if you have lots of salt and lots of fluid, well, it's going to end up in your blood vessels. They're going to distend and you can have a little bit more blood pressure. So the diet recommends less than 0.4 grams of sodium chloride per day. Now, I want you to go take a look at the soft drink that you have or some prepackaged food. Salt is everywhere. Patients will think, well, I don't add any salt. Well, that's okay. The manufacturers did. Keeping a diet below 2.4 grams is really hard, but that's the goal in order to reduce the blood pressure. Also recommended is the DASH diet, used for heart healthy and will help them lose weight. Also, potassium supplementation. Now I have to be careful with this one because if patients have chronic kidney disease or they're on medications that cause hyperkalemia, they may actually end up causing them harm. And this is supposed to be citrus fruits, not processed K. So this recommendation's in there also, so this is part of the diet. And lastly is alcohol. And obviously stop alcohol, right? And this comes in the 2 for a man, 1 for a woman deal. Recommendation, termination of alcohol is usually what you want to do. Exercise is actually less clarified now, and it's broken down into isometric exercises versus aerobic exercise. And basically, you want people exercising 30 minutes a day with a goal of 2 hours a week. And for some patients, it may just be walking around the mall or walking around the block, but getting them to move and eat better, less alcohol, is also going to cause the weight to go down. And this is actually very important. The recommendation is if you are obese or just overweight, That is, if your BMI is greater than 25, you should lose some weight. Doesn't matter if you're big boned, if you like the way you look, blah, blah, blah. If you're talking about hypertension, what you should do is lose weight if you're over BMI of 25. So radically changing their diet, getting them exercise way more than they used to be in order to try to get their weight down, well, that's going to take a little bit of time to implement. So these patients who just have an elevated blood pressure, who you're only initiating lifestyle modification, don't have to come back that soon. Give them a chance for it to work out. The next stage is less than 140 over less than 90. Here it gets a little complicated. So obviously lifestyle modification is going to be the way to go. But here they say, well, should we be putting all these patients on medications? Well, the answer is yes, if. Yes, if they have other comorbid conditions. The way the guidelines say this is a 10% ASCVD risk on the calculated score. Well, you don't have that access to that, right? So what does that mean? If you have another risk factor for coronary artery disease, which is the whole point of controlling hypertension, right? Peripheral vascular disease, cerebrovascular disease, coronary artery disease. Hypertension accelerates atherosclerosis. So the recommendation basically is, if you have hypertension and another risk factor for coronary artery disease, you should probably treat the hypertension. Smoking, dyslipidemia, diabetes, hypertension, obesity, age greater than 45 for a man, 55 for a woman, family history. If one of those things is with hypertension, you're probably going to get over the 10%, maybe. So if they have a 10% risk, you should start medications with that lifestyle modification. But only start one. And if they don't have this 10% risk and their blood pressure is that high, well, try the lifestyle modifications first, but bring them back sooner, because if it doesn't work, well, then you're going to have to do the medications. And anytime you start a medication, and this is what I like about these new recommendations, when you start a medication, come back in 1 month. The reason for that is, A, are you taking it? B, have you had any side effects? And 3, diagnosis and titration. The new guidelines have said this. They kept the same definition of hypertension. 2 readings, 2 weeks apart, 2 visits. But then they said, you know what we should really be doing is home blood pressure monitoring. Let the patient go home and take their blood pressure multiple times per day. As long as they do it right, the cuff at the level of the heart, the right size cuff, not within 30 minutes of exercise, caffeine, no smoking or amphetamines, right? Take the blood pressure the right way, but take multiple samples over the course of the day. Use telemedicine to assess whether or not titration is needed. And if you're going to titrate, keep the person coming back. Come back for the blood pressure check. They don't need a whole visit, but don't let them go 3 months if the medication needs to be titrated. Titrate rapidly and get the blood pressure under control. Find out how many meds they need and if the medication they're using is working. Stage 2 is greater than 140, greater than 90. This is, of course, lifestyle modifications, but lifestyle modifications are going to be downplayed substantially because now you need 2 medications or more. You're going to start 2 meds, and every time you start a medication, bring them back 1 month. 2 readings, 2 weeks, 2 visits, home blood pressure monitoring, titration through telemedicine services, etc. This allows us to catch masked hypertension, where you don't see it in clinic, but they actually have it. White coat hypertension, where they don't have hypertension, but you see it in clinic. This is going to be very useful in the future of medicine. The 2 medicines you choose are going to be based on comorbid conditions. Urgency and emergency briefly. The cutoff blood pressure is 220 and 120. And this thing that separates urgency from emergency is going to be signs of end organ damage. You will see the unit and medicine fight over this a lot. The elevated creatinine, the slightly elevated troponin, does that count? What I want you to see is, if you see a vignette where someone's blood pressure is 220 over 120 and they have signs of end organ damage, ultramental status, shortness of breath, chest pain, troponins elevated, creatinine, whatever the case may be, that person gets put on a drip and goes to the unit. 25% reduction in MAP in the first 2 to 6 hours, and then you can put them on the oral medications and glide them in. You do not drop them to normal blood pressure. You just slowly drop it on that's why you're using the infusion. Whereas hypertensive urgency, no signs of end organ damage, you can use IV medications followed up with their own orals. All right, so which medications are you going to pick for comorbid conditions? For heart failure and coronary artery disease, you're going to start with a beta blocker and an ACE inhibitor. And anytime we show ACE, almost always, except for the side effects, ACE inhibitor is an ARB. I don't remember which ones are beta blockers for this one, which ones are for that one. I just picked the ones to know that are for both. So the ones that work for both heart failure and coronary artery disease are metoprolol, carvedilol, and nebivolol. Those are the ones I remember. Notice the olols. If you've had a stroke, this is a brain, and I don't know why this is true, the combination of ACE inhibitor and thiazide is recommended. That's a gotcha. If you don't know it, you wouldn't figure that out. There's no reason to deduce it. So if you don't know it, you'd miss it. Chronic kidney disease gets an ACE or an ARB, except if it's stage 4. The small reduction in GFR from constriction of the afferent arteriole causes just a slight elevation in creatinine. And if you are already CKD stage 4, you may end up going into stage 5. So avoid in stage 4, but almost always in renal disease, whether there's protein in the urine from diabetes or there's chronic kidney disease of any kind, ACE inhibitors are the things you want to pick. For diabetes, this is the pancreas, ACE inhibitors are the choice. They actually say if there's microalbuminuria, I would say if you see a diabetic, it's simple enough to say, hey, try an ACE inhibitor, which is good news because for all comers, this is a carryover from JNCA, they say the same thing. For all comers who have no other disease other than hypertension, you can take your pick, hydrochlorothiazide, calcium channel blocker, ACE inhibitor, unless you're black, in which case you don't get an ACE inhibitor. I don't like that recommendation, but that's what the recommendation is. I would learn, if only hypertension, pick one. Thiazide, ACE, calcium channel blocker. And don't try so hard. The idea being if all they have is hypertension, the risk of giving them too much medicine is not worth the benefit. Okay. You're going to start with medications, and it doesn't really matter which one it is because they don't really have any other indication for any medications and they're not that advanced in their disease. So don't try that hard. Focus on lifestyle modifications. But if their blood pressure is high enough, yeah, you want to get them going. Okay, so what I think you're going to get asked about is probably lifestyle modification primarily, and then choosing which medications you're going to pick for the comorbid condition. And then lastly, it's going to be identifying side effects. And I think that's going to be where most of your questions are going to come from. So for each of the classes of medications, they're going to have a side effect that they're used to, and then some interesting part or note about them. First, the dihydropyridine calcium channel blockers, not the rate control agents verapamil, diltiazem. Those go in the don't use category. The felodipine, amlodipine, those medications. This is another sort of gotcha. It's right on the top of the list. The side effect is peripheral edema. And for the notes, these actually are anti-anginal. So it can be used in patients with coronary artery disease who are expressing chest pain. They are not useful in heart failure with reduced ejection fraction. The next class are the ACEs and ARBs. And I always lump these together except with one thing. Both of them are going to cause an increase in creatinine, 20% is okay, and they can cause an increase in potassium because they work on the collecting duct via aldosterone. They prevent reabsorption of sodium, so therefore K can't be kicked out. But only the ACE inhibitors cause the dry cough and angioedema. Because the ARBs don't work through bradykinin, they can't cause cough or angioedema. And in this recommendation, they finally said it. Do use ARBs after an ACE-induced angioedema. You're not going to find any provider who's willing to do that because for the entirety of 2000 to 2015, everyone assumed ACEs are ARBs and If you have angioedema on ACE, ARBs are going to cause it. They don't. The big thing, though, is the creatinine, potassium, cough, and angioedema. And, of course, their indication is basically everything, especially chronic kidney disease and diabetes with microalbuminuria. The last of the take-your-pick medications, all comers can get any of these, are the thiazides. Hydrochlorothiazide is what we use most often in this country, though chlorthalidone has most of the medication studies. These work in the distal collecting duct, and so can cause a decreased potassium, and also can be used to decrease the urinary calcium to treat kidney stones. While these are sulfa, they basically have no cross-reaction with sulfa reactivity, so you don't have to worry about that. But you do have to worry about depleting them with volume and then end up with potassium, low potassium. Beta blockers are next on the list. And beta blockers got downplayed in the last JNC 8 recommendation and now again, except in the setting of heart failure with reduced ejection fraction, and CAD, coronary artery disease, ischemic cardiac disease, however you want to name it. I learn and I teach all of my residents beta blocker, ACE inhibitor, aspirin, statin for coronary artery disease. Beta blocker, ACE inhibitor, CHF. Just do it. That's good for anyone who's had an MI or who has heart failure, systolic. We're not really sure if beta blockers is the way to go for a long-term effect 3 years after their MI, but I say if they're coronary artery disease, have them on beta blocker, ACE inhibitor, unless they have side effects. And the side effects of the OLOL medications, the beta blockers, is to decrease the heart rate. Yeah, there's that thing about obstructive lung disease, but basically it just doesn't happen. If you see obstructive lung disease being exacerbated by an oral medication, it's going to be beta blocker, but it's bogus. Plenty of COPD patients have beta blockers and they don't exacerbate because of their beta blocker for the MI they just had. And then we start getting into the ones that are less frequently used. Aldosterone antagonists. And I'm going to write out both spironolactone and eplerenone. Working on aldosterone, they work in the collecting duct and so prevent reabsorption of sodium, so it can also cause hyperkalemia, just like the ACE-ARBs. But this comes up on the test because spironolactone causes gynecomastia. And if you see gynecomastia, then you should pick eplerenone. Aldosterone antagonists are really only used in 2 places. People who have really resistant hypertension and you're going to start working them up for hyperaldosteronism, either primary or secondary hyperaldo, or in CHF class 3. Everybody gets beta blocker ACE inhibitor, then loops, then more blood pressure control needed. Either aldosterone antagonist or the combo dilators. The arterial dilator hydralazine, the venodilator isosorbide dinitrate. Hydralazine dilates arteries, which can cause a reflex tachycardia, and also drug-induced lupus. Isosorbide dinitrate dilates the veins, so should not be used with other nitrates or the phosphodiesterase 5 inhibitors. Using this with other nitrates can cause an unsafe drop in blood pressure. Together, hydralazine isosorbide dinitrate is the trade name Bidil, which is also used in class 3 CHF, just as the alternate choice to aldosterone. These can be used independently because the nitrates themselves are anti-anginals. So they can be used for coronary artery disease. Hydralazine is usually used in CKD5 3 times a day. Combine them, and you have medication for CHF. There are other medications that people like to use for hypertension. And there's a middle ground where, yeah, you can. Those are the doxazosin, terazosin. They're supposed to be used for BPH. But the idea is, hey, they got BPH, you put them on that med, their blood pressure got controlled, great. Just use that, don't add on anything else. But I want you to see that these generally do not control blood pressure. What they cause is orthostatic hypotension. And the medications you should not use are the central acting medications, such as clonidine. Clonidine should be avoided because it causes rebound hypertension. This can be avoided using a transdermal patch instead of the TID oral dosing to avoid the rebound hypertension, increase compliance, but clonidine should be medication of last resort. Also on this list are the non-dihydropyramine calcium channel blockers, verapamil and diltiazem. These are rate control agents used for AFib. Very importantly, they do not replace beta blockers when it comes to heart failure and coronary artery disease. Even though both beta blockers and calcium channel blockers are rate control agents for AFib, they don't have the same benefit when it comes to heart failure and coronary artery disease. Yeesh, that's a lot, huh? Well, I want to cover special circumstances very briefly. I'm not going to write on the board. There was a big to-do in JNC 8, which said, hey, you know what? Some patients need a more lenient blood pressure. So everyone should have a more lenient blood pressure. AHA came back and said, well, sure, the special patients who have problems with blood pressure should not have such a tight blood pressure goal. So people who are at the end of their life, institutionalized in nursing homes, don't try so hard. You don't want them to pass out. People who are on dialysis, don't try so hard. And use their dry weight blood pressure so that if they go up in between sessions, it's okay. You don't want them tanking while they're on dialysis. And people who have dysfunctional autonomic systems, the elderly, diabetics who have trouble with orthostatic hypotension, take their blood pressure standing up. Right? It's kind of common sense things, but it has to be said because otherwise you're going to titrate people into passing out, which you want to avoid. It'll be an adverse medication event. The new system is a little annoying. You just have to see the 120, 130, 140 greater than for systolic. And remember, diastolic is 80, 80, 90, 90. The big thing is lifestyle modification first for almost everybody, unless you have a risk factor for coronary artery disease stage 1 or R stage 2. Stage 1, 1 med, come back 1 month. Stage 2, 2 meds, come back 1 month. And the big push has been use telemonitoring, home blood pressure monitoring, ambulatory blood pressure checks to get a good idea of what's going on during the day. And then simply have to memorize the comorbid indications and then the side effects with some of the bonus features, and that'll get you through most of hypertension. That is hypertension.